On to the next presenter, which is Esmeralda no TAM, and her talk is on census data reveals inequity in self-identified visual disability in New Zealand Atoria.
Namaste, kia ora koutou, tālofa lava, and warm Pasifika greetings to you all. My name is Esmeralda Lotam, and I am from the most southern part of the South Pacific, New Zealand. And today I'll be talking to you about the census data, which is a nationwide survey carried out every 5 years in New Zealand. So looking specifically at the 2018 census, this was the 34th census in New Zealand, but the very first one to be completed online. It was also the first to ask the question, do you have difficulty seeing even if wearing glasses? Now, Pasifika health is detrimental to the health status of Aotearoa New Zealand, because if we reflect on the population increase, we see that the Pasifika population has increased exponentially over time. Now, this table we see shows a prediction of answering the questions on self-identified visual disability, where subjects were more likely to answer if they were older or female, and less likely to answer if they were Māori or Pasifika. And comparing the three ethnic groups, and taking the females for example, we see that the other ethnic groups, the bars on the far right, have significantly less self-identified visual disability in both age examples in comparison to the Māori and Pasifika in both age groups used here. So now let's paint a picture of Pasifika life expectancy versus the total population in New Zealand. And what we see is the Pasifika population pyramids on the left reveal a bell-shaped curve which reinforce the impact of early life risk factors, such as smoking and obesity. The general New Zealand population pyramid show a more even distribution, reflecting longer life expectancies with lower burden of early life chronic diseases. And so what does this mean in relation to visual health for Pasifika communities? The consistent age structure over time means that long-term planning for youth-focused visual health services is essential. Therefore, there's a greater need for earlier prevention and intervention strategies in eye care for Pasifika communities. Of course, with any study, there are limitations, and there was no exception to the census here. One of the major limitations was that we had received the lowest response rate in over 5 decades, a 9% drop from the previous 2013 census, and well shy of the 94% national target. Implications were said to be due to this being the first online census, and implications or challenges that come with that, like are people digitally literate? Do they have access to a computer or to internet? Despite this, there are various benefits, and that's what I want to highlight here. It is a big data set. It's the first of its kind, which is new, and it's very exciting. And although it's limited data, it is the most complete that we have at this stage. So overall, the intention of this research is simple, to have more equitable incentives and initiatives. So more Pasifika-based research to provide stronger evidence for Aotearoa and the Pasifika nations, to have increased accessibility to eye health care and remove barriers for health care for marginalised and Indigenous populations, and also to have preventative care prioritised and health education. Of course, none of this research would be possible without my wonderful supervisors and sponsors and scholarships, who have flown all the way here from New Zealand just for today. Thank you for the opportunity.
Thank you for that nice presentation, and we open it up for quick questions. I just wanted to ask you, what proportion of the Maoris and the Pasifika, right, that group, yes, what proportion of that comprises the overall population? Like,
that is a good question. That's a question that I don't have the answer to right here, right now.
And the second follow-up question to that I had was, you said that there were barriers in seeking eye care. So what were the potential barriers?
Some of them are language. For Pasifika people in New Zealand, English is still a second language. And even when we translate it into Samoan or Tongan languages, the medical terminology is also different. So I guess the health literacy around understanding getting preventative care earlier rather than later when it's more severe and complicated. Yeah.
It's okay. If there are no more questions, thank you very much.
Sorry, I haven't got rid of me yet. Okay. Yeah, sorry. All right. Now we turn our gaze to understanding. Oh, what happened? Now we turn our gaze to understanding the state of ocular disease and inequity disease burden among Pasifika residing in Aotearoa. According to the Global Health Commission, eye health is maximised vision, ocular health and functional ability, which contribute to the overall health, well-being, social inclusion and quality of life. So what is the cost of visual impairment? And on an individual scale, this means poorer quality of life. So not being able to see a whiteboard in a classroom, for example, which restricts access to achieving good grades academically and professionally, and therefore becoming more reliant on social care. On a societal level, global productivity loss due to visual impairment is estimated to cost $410 billion annually, a huge economic strain on a country with limited resources. And so what does this mean for New Zealand? With a population of just over 5 million, Aotearoa is a small developed country, and in comparison to where we are sitting today, look at where Aotearoa is, geographically isolated from the rest of the world. Furthermore, the New Zealand health system is predominantly publicly funded, which puts huge pressure on an already strained workforce and its resources. In 1945, Pasifika made up less than 1% of the population. Fast forward to today, we make up approximately 8%. However, it has been reported that Pasifika experience disproportionately poorer health outcomes, which extend to eye problems. So a literature review was conducted to understand the state of eye health for Pasifika in New Zealand, identify barriers, and look at future directions of eye care. The literature review was conducted in September of 2023, and keywords were used to combine and modify the results. Over 600 papers were retrieved with our key concepts. However, 42 papers met the criteria. So, what were the findings of our review? Core reports showed that the literature review identified Pasifika eye diseases fell into these areas. Pasifika are overrepresented with keratoconus in Auckland, with more severe disease progression and younger age of diagnosis. Now, this is the stat that I find very interesting. Although we make up 8% of the population in New Zealand, around about 43% of corneal transplants are required for Pasifika people, keratoconus eye drops. There's an overrepresentation of Pasifika who have cataract, and that's thought to be due to lifestyle, things such as diabetes, cigarette smoking. Cataract is the most frequently performed surgery in Aotearoa, where 50% of surgeries are in the public system. And although Pasifika have lower rates of health insurance, 50% of surgeries are in the private. And we present with cataracts 10 years earlier as well than the general population. In Aotearoa, approximately 1,200 deaths are caused due to diabetic complications, where 90% of diabetes in Aotearoa are type 2. And Pasifika have twice the rate of diabetic complications in comparison to the general population. Despite AMD being the leading cause of blindness in New Zealand, we have the lowest funding of AMD treatment in the OECD and a relatively low ophthalmic workforce. In relation to Māori and Pasifika, there are low reported numbers of AMD due to low utilisation of health services. For glaucoma, there is currently incomplete data available for Pasifika. Cost is a major barrier as treatments are not publicly funded, making regular checkups less affordable. And in some regions, people need to travel long distances for care, so access is limited. Missed checkups delay recovery and impact long-term eye health. Oh my gosh. But one of the biggest challenges culturally are our priorities. As Pasifika people, we often put our family, our church, and our community obligations before our own health. And that doesn't mean that we don't think our health is important. Culturally, it is our obligation to put God first and then others before ourselves. This then translates into how we perceive our own health priorities as being second to everyone else's. This mindset can lead to delayed care and worsening of vision conditions over time. My aspirations for this research is to have equity-focused initiatives to improve outcomes for marginalised populations, so that families like yours and mine can thrive in today's world. We can transcend boundaries of ophthalmology together. Thank you, APAO.
Inequity exists beyond Aotearoa, New Zealand. So can you use this information to suggest some broader directions?
Yeah, that's a really good question. And I think in Samoan we have a saying, e fole ala mea le ala mea. So what we do is, that means that the solution lies within the community itself. So that's where we need to start, in the backyards and in our own homes. And I think what we want to do is take the vision screening out into the community groups, of course with our leaders and the knowledge and things like that, and be able to put it in a way where, to answer your question before as well, so that we can break down that knowledge, make it easier for people to understand, and have it not only in their languages, but for us Pasifika, we're not always able to read and understand things straight away, but visually, that's where you can capture us. So things like videos, breaking things down into learning information in different ways, and not just the usual classroom kind of setting. But yeah, does that answer your question? Sorry.
Yes, definitely. So in India, I'm sure that will be quite relevant as well.
Yeah, the other thing I wanted to ask you is with regards to the strategies, like monitoring, for instance, whether when they have a condition. So are there strategies of the government to kind of decentralize the care, in the sense that they don't have to come to cities all the time or into big tertiary centers, but are there other centers which can kind of handle this kind of regular monitoring? For instance, if it is refractive errors, you can have primary health care centers and others who could be trained or equipped to kind of deliver. So are there such strategies also in the...
That is also a really good question. And what we saw during the COVID outbreak and the pandemic, what New Zealand did really well is work around communities. So there were community hubs where things like churches, marae, those kind of groups, where people would go to and not only have information distributed and health awareness given to them, but doctors and nurses were able to come into those communities as well and share their knowledge. But also, I think with the follow-up, it's also having it in their own areas where they're comfortable. Once they are equipped with the knowledge there, then they'll be more comfortable to go out into primary healthcare and things like that for follow-ups. Yeah, I hope that answers your question. Thank you for your